Well, good evening, dear colleagues and students, friends. I'm Professor Dyer Reddy, Vice-Chancellor Interim of the University of Cape Town, and it's my real pleasure to welcome you to this inaugural lecture, which is going to be delivered by Professor Michael Held, who is the Director of the Orthopaedic Research Unit in the Faculty of Health Sciences here. And he's also a consultant in the Department of Orthopaedic Surgery at Groote Hospital. I'm also very pleased to have been introduced to members of Michael's family who are all here. Where are they? Oh, there you are. Welcome. Wonderful to have you here with us on a really important occasion. Allow me to introduce the platform party for this evening's event. So on the left here, we have Professor Lydia Cairncross, who is the head of surgery in the Faculty of Health Sciences, and she will introduce our inaugural lecturer shortly. Then we have Professor Michael Held, and our lecturer, of course, and on his right, Professor Maritz Loubser, who is also an orthopedic surgery consultant at Groote Hospital, and Maritz will later on deliver the vote of thanks. Then we have on his right Professor Elalwani Ramugondo, who is the Deputy Vice Chancellor for Transformation, Student Affairs and Social Responsiveness, one of my executive colleagues. And then at the far right, we have Professor Lionel Green-Thompson, who is the Dean of the Faculty of Health Sciences, and he will later on deliver the closing remarks. So, colleagues and ladies and gentlemen, inaugural lectures are really important. They're a very special event in the life of the university. They mark the ascent, if you like, to full professorship, which is the highest academic rank, and it's one that is aspired to by any serious scholar. Whether one is appointed to the rank or promoted, either way, it constitutes recognition of the stature of the individual and of the high quality and impact of their academic work. I can tell you that the process leading to becoming a professor is an arduous one. It's a real obstacle course. The criteria are demanding, and so the rank is all the more prized. Inaugural lectures provide an opportunity for the professor to, well, first of all, for all of us to celebrate the achievements of the new professor, the lecturer, together with them. But they also, very importantly, provide an opportunity for all of us to hear from the lecturer about his insights into his scholarly work and to present these, share these with us in a way, in a manner that will be accessible to a broad audience, certainly an audience that goes well beyond the discipline of orthopedic surgery. And so they tell us something of what they profess, if you like. So by increasing our understanding of Professor Held's work, we also build our understanding of the learning experience for forthcoming or future professionals in the field of orthopedic surgery, including the benefits of student-centered content co-creation. So this is a relatively new approach to higher education around the world. The benefits that analysts have identified in student-centered content co-creation, so as the name or as the title indicates, it's about education, but about going about it in a manner in which the student is not simply there as the recipient or the receptacle of whatever is presented. So the benefits include a strong sense of engagement, enjoyment with the learning process, taking risks, overcoming challenges, stronger relationships within the classroom and with community members, and of course, stronger retention ultimately of the course material. One analysis goes so far as to state, and here I'm quoting, we conclude that the risks and challenges inherent in curriculum co-creation may in fact be exactly those conditions that are conducive to student transformation, unquote. UCT's Vision 2030, the strategic vision and plan, expresses our commitment as an institution to building a practice of teaching and learning that will in fact transform society through our graduates, our students and our graduates, by enhancing the leadership potential of our students through skills such as team building, problem solving, creative thinking, and critical thinking. All of these are skills that are emphasized through the practice of student-centered content co-creation, and skills which will serve them well, serve our students well, and all of us for that matter, well beyond whatever their careers might be, their lives as a whole. These skills also promote excellence in any sector. Excuse me. They promote excellence in any sector, any discipline for that matter. Tonight we are learning and hearing about this in the context of orthopedic surgery, but much of what I've had to say really is completely independent of the specific discipline. And these have been identified as among the necessary qualities for leading society through a, or shall we say, in an era in which we are witnessing rapid changes. We have significant problems, of course, that we contend with in South Africa and generally, but we are also witnessing very rapid developments, for example, through digital technologies. Think also about the developments in biotechnology and many others. Very rapid, hard to keep up with them, and this really is the world that our students enter once they leave university as graduates and take up their careers. So Professor Held's approach, which we'll hear more about shortly, is certainly one way of expressing the central mission of Vision 2030, which is to unleash human potential to create a fair and a just society. And with that, I will now hand over the podium to Professor Cairncross, who will introduce our inaugural lecturer. Thank you.
Good evening, everyone, and thank you very, very much. Welcome to all of you here tonight. It's my great pleasure and honor to introduce Professor Michael Held to you to celebrate his work and his promotion to full professor. Greetings to everyone, and in particular to Michael's wife, Joanne, his children, Noah, Hannah, Maya, and Olivia, his brother, Thomas Held, his parents, Franz and Magdalena Held, who are joining us online. I'm very pleased you're all here today to celebrate his work. I'm going to tell you a little bit about Michael. He's asked me to be extremely brief, but I don't always take well to instructions, so I might be a little longer than 2 minutes. I want to give you a little bit of a snapshot of his career and then some quotes from people that are close to him, both in his career and in his personal life. So Michael was born in Munich, Germany, notably from a family committed to health and education service. His father, Franz Held, is a doctor in sports science and was academic chair of the sports center at a university in Munich, and his mother was a teacher. All of his siblings, Ursula, Andreas, and Thomas, are also involved in either teaching or health professions. And Michael has followed on with that tradition and has come to have an impressive academic medical career. First, the degrees. So Michael graduated both his undergraduate and MMed degree cum laude. He has orthopedic specialist degrees both in South Africa and in Germany. He has completed a PhD at UCT and an MBA with the Graduate School of Business. It's tiring even just to say them all out like that. Michael began his orthopedic training in Munich and then continued at UCT, with his first few years as a supernumerary registrar in an unpaid position within the Division of Orthopaedic Surgery. In 2018, he was appointed into a consultant position. And in addition to his standard clinical teaching, and research outputs that are required of every consultant specialist, it rapidly became clear that Michael was on an accelerated path. He showed his incredible talent both for innovation and teaching, rapidly obtaining his PhD. He established the Orthopaedic Research Unit, and he reviewed and improved the undergraduate student syllabus, making it more focused on primary care and accessible online. He also had the foresight and initiative to establish an MSc in global surgery, even before we had a division of global surgery at UCT, and at a time when global surgery was a little-known field of surgical inquiry. Through the Orthopaedic Research Group, he's encouraged interdisciplinary research with colleagues in immunology, biomechanics, sports medicine, and many others. And his commitment to research and scientific rigor has been instrumental in bringing scientists into orthopedics as postdocs, and he has overall stimulated the PhD program, both in orthopedics and in surgery. So that was a high-level snapshot. Now for some quotes. First, Professor Steve Roche, who is here today, is a mentor and colleague of Michael's, and he said, "I first met Michael when he was a quiet, respectful." Now, I'm not sure why he said was, but I'll just leave that. When he was a quiet, respectful, and extremely enthusiastic young medical officer. He asked to come and sit in with myself and Professor Basil Freitas in theatre and watch some operations. The next thing I knew, said Steve, I was examining him for the intermediate exams, and he was on our orthopedic rotation. Working with him, I have come to appreciate his qualities: determination, organization, ambition, and tremendous capacity for hard work. Michael's first love was shoulder surgery, he says, but we lost him to knees. Professor Roche claims that this was because he was intimidated by Michael's magazine cover looks. He said it somewhat differently, but I've edited a bit, Steve. Others say that he went to knees because he showed talent in that area, but whatever the reason, Steve encouraged Professor Dunn to assign him to the research portfolio and the knee surgical service. And among other things in this portfolio, he started a sports injury clinic for young athletes in the public health system, a service that could only previously be accessed through private health insurance. My next quote is from Dr. Richard van Bornman, a very close colleague and friend of Michael's, who said, "Mike is a naturally gifted surgeon, educator, and researcher, and just an exceptional human being. He's an all-round wonderful guy, wonderful father, and wonderful friend. I think what makes him really special is that he's of a rare breed of people who want every day to be better at all of these things. It's a special person who wants to be better at something today than they were the day before, and Michael embodies this." His brother, Thomas Held, says about Michael, "There are 1,001 stories I can tell about my brother, many of which are very interesting and very funny, but he says, I'm not sure if he'll forgive me if we say all of them here." So he didn't give me the stories, Michael, don't worry. But one thing I can say is that he has always been the big brother in our family. And by this, he was always caring for everybody. And he enjoys any experience more if he is sharing it with others. I think that's what really stands out for me about my brother, his desire to share these experiences and to support others. And then before coming to his wife's quote, Joanne, I just wanted to mention, in case Michael doesn't say it in this lecture, I'm sure all of you might be wondering how we managed to recruit from Germany this very talented surgeon and scientist to UCT and to Cape Town. I mean, obviously it was the university and the academia and the city and so on. But the answer also lies in a personal story. So Michael was introduced to Cape Town first as a medical student, and I quote him when he says, "I was one of those visiting German students." Fatefully, during that 3-month elective, and luckily for us, he met Joanne Strauss, former Miss South Africa, and then top billing presenter. By the end of his elective, Michael felt compelled to return to South Africa and stay the course to become a South African orthopedic surgeon, and the rest, as they say, is history. His wife, Joanne Strauss, says there are many things to say about Michael, but what most stands out for her and amazes her is his incredible tenacity and almost audacious optimism. He showed this in the many, many hurdles he overcame to become a surgeon in South Africa, including having to redo medical examinations, working unpaid for many years, and getting a South African residency, and I think most impressively, his HPCSA registration, which is not easy. And yet she says he did this all not at the expense of his family, who he always put first. When they met, Joanne remembers him saying that one day he wanted to be a professor. She thought that was a bit uncool at the time, but that now when she sees what it means, she's incredibly proud that he has achieved this and many other goals and remained a great husband and father at the same time. And then my last quote is from Professor Robert Dunn, who is the head of orthopedics and Michael's boss, who was very complimentary of Michael. And those of you who know Professor Dunn knows that he doesn't wax effusively in praise of people without there being due cause. So this is high praise. And he says and attests to his impact saying, Michael is restless in innovation, moving from one project to another, whether it be public-private collaboration around knee surgery at Milnerton Mediclinic or postgraduate knee arthroscopy, training by simulation and cadaver workshops. And all of his innovations are accompanied by high-quality research and, without fail, a publication. He has taken our orthopedic division to a new level with his research drive and ability to link this to all aspects of service and teaching. He is a massive asset, not only to our division, but to the entire university and the greater South African orthopedic community. Please join me in welcoming Professor Michael Held to the podium.
Are you gonna make me? Yes.
I'll just say forward or backwards. Yeah, I think she's got it. She's got it all. She knows, yeah, she knows how to press my buttons. Lydia, thank you very much for this very kind introduction, and also to the VC for this very interesting look on what I do. I almost don't have to give my talk anymore because you've got all the points there. But I also want to just appreciate their leadership. It's been tough for the hospital, it's been tough for the university, and those guys are putting their hearts and time and effort into making it a better place. So I wanted to ask you guys just for a round of applause for Lydia and the Dean and the VC. Thank you very much. And, you know, normally I'm quite intimidated by the audience, but I see a lot of familiar faces. Actually, all of you are familiar to me, but all are from very different places and very different walks of life. So it's not easy to reach a 3-year-old. She's awake, and then a 80-year-old Steve Roche, who's also asleep. No, I'm kidding. Let's start with this talk, and I want to talk about bones, and it's not that difficult, and I'll make sure that all of you can kind of come along on some of the stories. So let's click on. Can you turn it so I can see a little bit what's happening? Yeah, perfect. So I want to take you from one beautiful mountain to another. This is the Alps, and this is the country that I grew up in is actually, well, the region is called Bavaria. And it's got mountains and lakes. And if you click on, so if those mountains turn white, the Held family gets very, very restless. We love the mountains. We're in the mountains all the time. All of our, my brothers, sisters, my uncles and aunts, they can all ski. And my father was a huge driver in it. And as you know, Lydia was mentioning, he ran this unit, but he was pretty much in the mountain the whole winter. So if we needed to see him, we needed to actually put on skis and get into the mountain. So you can imagine, now you can see Joanna's on this picture, and she's very timid. She's cold. She wants to be part of the family, but it's just not happening. And so I said to her, look here, I'll teach you skiing. And I took her to a nice blue slope and I pushed her down and she went down. And next day we went to a red slope and then the third day we went to a black slope. And you can see that we standing on that spot up there. I said to Jen, look here, let's get out of this avalanche risk area and let's just cut across. And I could see her bottom lip just quivering and a little tear running down. And my dad said, no, Michael, this is the wrong approach here. Jen, come with me, you're safe with me, just drive behind me. And he showed us some easy ways to get down a mountain. And he would say, Jen, please, whatever you do, make sure that you don't forget to smile. And sometimes we forget when we teach people that they need to enjoy it. And, you know, it's often something that you force onto someone and you don't actually, you want them to learn something, but you don't really want them to experience it, or you don't know that they should experience it in a joyful way. And the other thing, he was a craftsman of teams. So when we went rowing, he would say, okay, Michael, you sit here in the front, you steer the ship. And then Thomas, you're gonna pull hard. You're gonna push the ship forward. My sister was doing the rhythm, so you need someone to just keep the rhythm. And then he was making sure that we wouldn't tip. And it's a way that really brings people in, and it's a way that's very reflective when you do it. It's a calm way where you focus, and it's oftentimes something that I feel when I'm in the operating room. Today I operated with Sister Isaacs, and you know, oftentimes you're just in the zone and everybody works together and things just click, and it's that teamwork that we need when we work, but it's also the team that we need when we teach. And my mom, on the other hand, she's wild. Very wild one. And they call it a wild cat. And so she doesn't like authority. She doesn't like a lot of people. She doesn't like big crowds. And she's very individualistic. So when I had to go and be part of that, it was very difficult for me. And it's not a safe place to be either. So oftentimes you have that boat tips. There's no one that keeps that boat alive or on top. But we, when I asked my mom, so what must I do for my kids? You know, how can I help them? How can I make them, prepare them for life? She said, well, why don't you ask them? What do they want? What's their dreams? What do they want to learn? And then you support them in that. And sometimes we forget about that too. In our students, we don't actually ask them, where do you want to go? We just tell them, yeah, this is what you need to learn, but we don't know where they want to go. And oftentimes we don't even ask our family or partners, and it does give disconnect. And so if you ask people where they want to go, you can be part of that journey. Now, these are my brothers. They're often here in South Africa. And actually, I thought Thomas is coming for this lecture to visit me. But he's actually brought a beautiful young lady, Anne, who's fantastic to have in our house. And I think he's mainly here just to show her around. But it's nice to have you both here as well. So unfortunately, there's no mountains with lots of snow here. And so I had to test uncharted waters. And you can see all these people are trying to make me into a surfer. Bryn is a perfect scout when it comes to waves and swell and wind direction, and he knows everything. And literally, you jump into the water, he's like, no, Michael, that's the wrong foot. You know, paddle now, paddle, no. And so he's a perfect person to know where to go, when to go, and to have in the water. Maritz, I only go surfing with Maritz when no one is in the water, because it's usually very stormy and usually very, very late. And afterwards, it's always like, Michael, that was fantastic. It was fantastic. He just works so hard that anything for him outside of work is fantastic, Michael. And Maria actually got me into kiting. So Maria is sitting here in the corner, and he's said to me, Michael, I don't want you to leave Langebaan. I was there for a week. Before you can't kite. And I had a massive conjunctivitis afterwards because I was always looking up at the kite, but I managed to stand up and he got me into kiting. And then let's click on. So you obviously want to know why I'm here. And yes, we've had some stories about that. It's the place that is, especially on a Sunday, it's very dangerous to be, especially when it's pink like this. And then I met this beautiful young lady. Yes, this is one of the, I don't want to say old pictures, but it's one of the, I found it somewhere on a website. Anyway, we started to co-create, and this is how I want to introduce co-creation. Now, co-creation is something when you have one person and another person, and they work together and they achieve something that's beyond amazing. So we got pregnant, and we got more pregnant and more pregnant. So mainly for the last 6-7 years, she was pregnant. 8 years, she was pregnant and literally running her business at the same time. And we got these beautiful kids. So we've got Noah. Noah is, he loves soccer, loves to build, loves airplanes. And that's it. That's mainly. Whenever I come home, Dad, let's play soccer. Although he likes rugby now more after the World Cup, but soccer mainly. And then we've got little Hannah. Hannah loves our rooftop. It's very dangerous up there. She loves going on dates with me. And she loves the last sip of my coffee because it's so sweet. And she always really indulges. And she loves her brother. And then Maya also, she loves mango lassi. She loves avocado bread, Maya. And she loves her sister, her little sister. Yeah. And then we've got our little one, that's Olivia, and she loves flamingos. And she also loves her little sister or her big sister, and she loves dresses that are the dresses that she chooses. She doesn't like us to choose her dresses. So she wants to be the boss in the house, and she tells everybody what she loves. And so these are our kids. And this is probably the biggest achievement. Like all these other things don't really matter. And now this is what Joanne does in the house. Pretty much everything. So she cooks, she cleans, she packs the lunch boxes, she goes takes the kids to school. She does all the shopping. She loves changing nappies, always with a smile. Goes to the gym and she always takes 2 or 3 kids along. It's amazing. No, when she's go back. So, but she's not. It's not just that. She does all the DIY at home. If we had a farm, she would look after the farm animals too. And she built a house all by herself as well. Anyway, and let's go on. So, what her dad is also here, and I think what is really important with her dad is that I realized that you don't have to talk to teach. You can just sit there, you can listen, and listening is actually very important. And you can just be, and the being is almost more powerful than the talking. You can basically show someone what is important in life, and the big things that are important in life can't be taught by teaching someone words. So we learned about love, care, compassion, and how to take my wife to a ski holiday all by himself without me. And he was pretty much in the mountains. They were living on top of the mountains, and he just looked out and he was amazed by the mountains, and he didn't ski. So I just wish I was there just to push you down that red and the black slope a little bit as well, just to give you the first push. Next time it's my turn. So that heart reminds me that I have to give you the flowers from me. That's the flower in the sash. Jen knows how to wear that. Okay, so now let's go to the actual talk, the academic part of the talk. And what I just explained to you are the 3 concepts that I think are very important in our department. They're important in my family, but they're very important in our department as well. And that's pretty much to keep on learning, to listen to people, and to support these people that you're listening to figure out what they want and to push them and achieve their goals, or achieve at least a journey to their goals. And we need a good team to do that. So the next question that I always asked, and it was a little bit rough with Rob because he actually asked that question to a lot of the people in the department, and it was a 360 basically. So you were asked, what's my value? And people gave that value that they thought you had, and you were rated. And it disturbed me because I saw my value was completely different what other people perceived my value is. And I was in Langebahn with Robin, and she said to me, you know, Robin Brink, she said to me, look here, I think the best way to find your value is to see what you love, to see what you're good at, what you get money for, and what other people need. So if you're in that sweet spot, then that's really where your value is. You can move around a little bit to one of these corners, but you should always have those 4 things in your life. And so as orthopedic surgeons, I think a lot of the surgeons in this room, and I think most people in this room that aren't surgeons, that have something in their life that's valuable like that, it's very powerful because you can align your work to it. And for us in orthopedics, it's mainly the operations, it's the innovations around the operations to make it a little bit better, but it's the teaching. I think as a university hospital in South Africa, our main goal is to teach. We sometimes forget this because we're chasing grants or publications because they're easily counted. But the teaching is actually what really is important to South Africa. The capacity that we build with teaching surpasses things that we can operate with our own hands. Lydia also mentioned that in her talk, is that it's a real privilege to do that. And teaching is not a two-man show or two-women show. It's not a teacher and a student, but it's a whole system that needs to work. So we're talking about the university needs to work, theater needs to work. Our nurses are a huge part of our teaching. Sister Portia gives me lectures almost every week when the door closes and something on the list didn't happen as planned. But she is pretty much the boss in theater, and she makes sure that that theater runs so that we can use it to teach. And that's a huge part of the university as well, our university hospital, that we sometimes just accept. So our anesthetist, I saw Ola here, she's working with us in the operating room, but she's also thinking with us about how to make things better, how to improve arthroplasty, knee and hip replacement surgery. Adri is here, she's my anesthetist in private practice. Without her, I'm nothing. Patients can't actually be operated without being asleep most of the time. Okay, we can go on. And before I forget, lots of physios that basically take the patients, make them better again after we hurt them a lot, and bring them back into their life. And I see a few physios up here as well. So I really appreciate you in my life and in my working life. Now, the eldest, the oldest, the parts of our department is Steve. I think Mike Solomons is older, he said, but I think Steve looks older than Mike. And Rob. And so there's one that's hard, that's Rob, and he likes to step on toes and ruffle feathers. But you know, he's actually soft in the inside when you really need him, and you've got a huge problem. He really helps you, and he helped me with a lot of things that I was struggling with. And he supported me whenever I needed his help. Now, Steve, on the other hand, no. Steve is very gentle unless you make a locking screw 2 millimeters too long, or unless you've missed undisplaced clavicle fracture in a polytrauma patient, then he'll just fold you that day. You'll be crawling out of the hospital, and as you crawl out, he'll say, "I'm sorry, I should have taught you better. I'm sorry." And he feels it. He really feels sorry that he didn't teach you better. but Steve has been a great mentor to me, and he's like a father figure in our department. So we call him Papa Roche, or Grandpa Roche now. Okay, so now I want to get to Steve and Rob. Actually, they realized that our medical students weren't doing too well. They didn't really retain knowledge, that they couldn't pass exams that were set up for interns. And we realized we only had very short contact time to them. So we have a month to teach them about orthopedic care, and they have to then go to the private practice or a primary service, and they have to treat a lot of patients, a lot of orthopedic patients. And there's a huge disconnect in that. And so we had to figure out what to do to change that. So what they did is we had a complete teaching revamp about 10 years ago, 7 to 10 years ago, where we focused on trying to get people becoming primary care physicians with an orthopedic knowledge. And that should be symptom focused or symptom orientated. So when they see a symptom in a patient that's orthopedic, that symptom should be picked up by them and should be treated. And we try to basically invite them into our units and invite them into our operating rooms. And this is Mike Solomons. Now he's always got an eye on you. He's a hand surgeon, and he looks through these long loops, but he always know what's going on. And he's one of the main proponents of having students with us. And I don't know if Vela and Pinda are here, but Vela, hey, I think Vela is not here. They're twins, so it's always tricky for me. But they showed us, they really basically mentored us. They were students initially with us, then they went to Harvard University to get a master's degree in medical education, and I actually visited them there. So this is a picture that I took while they're showing me Harvard, and it was amazing to see. We went into this big lecture room, there was no one there. And I said, no, but it's probably between lectures now. No, that thing is empty. And I said, well, where do they teach? And then we walked past these rooms, and there were small rooms with lots of people sitting around small tables, and they were talking to each other. There was no lecturer there, really. And I said, what are they doing there? They said, no, they're getting problems, and they have to solve these problems. They get a test, and if you pass the test, you're allowed in that room. And then they talk to each other, and they're trying to solve problems in that room. And that's how they learn. They learn to communicate, they learn the weaknesses and strengths of their group, and they learn also some knowledge. And that really helped us. And it was a mindset for us that we need to somehow change the way we teach to get closer to that. And so we tried to start and write our own story. That means we wanted to own what we teach. It's not a book that you buy off the shelf that comes from the UK that you can teach someone how to do orthopedic primary care in South Africa. And so we asked the question, what skills and knowledge should you teach? And so we asked this question not just to orthopedic surgeons, but also to students and interns. So people that we wanted to reach, and they gave us a list. And that list was a long list with symptoms, basically cases, skills and knowledge, and they were prioritized. So we knew what they really wanted to learn. And then we kind of grouped that, and we saw that most of it was trauma and infections. So that was very important for people to understand in South Africa, in the emergency setup, and in the elective or in the patients that don't have emergencies. It's important for people to understand how to treat pathology without surgery. And go back. What was interesting to us is that was taken up at the JBJS, which is a Journal of Bone and Joint Surgery. It's an American journal. It's pretty much the highest impact journal on orthopedics, and it showed us that they're also thinking about these things, and they want to understand, and they want to have this guidance as well. So what Jimmy Kauta did, he basically tried to match that. So he looked at people referring patients to him, and he counted where those patients were sore, and then he try to overlay it and see if that is the same as what we saw in our consensus study in our previous study, and he found it was pretty close. So we have a curriculum now that's not just based on asking people, but it's also based on our real referral patterns in our hospitals in Cape Town. So that allowed us to really ground our curriculum into the problems that the people see that we teach. And so it was also published in the American Journal. We should have published it in South Africa. So how do we create this content now? So Prof Reddy said, you can obviously now, I can now say to Prof Reddy, I'm going to teach you about orthopedics. But he might be coming from a completely different viewpoint or culture or background. And so what we need to do when we create content for our students is we need to involve them. That way you get buy-in and you can actually talk in the language that they speak and you can reach them a lot better. So we had this list and we wanted to make a book, and we wanted to augment that book with a few things that are a little bit more fun than reading lines. Okay, and that book actually reached. We were awarded the Open Book Award for that book at the university, and that's when we realized, oh, this is actually something that's a little bit bigger than the orthopedic department. And that's where we really started to understand co-creation or learning about co-creation. And I wanna ask Glenda and Michelle and Bianca, they're here, and I wanted just to say to you that I really appreciated you on that journey. So they led us through this. They are from the Innovations in Teaching and Learning Center at the university, and they came and said, look here, you need those three people. You need students, you need registrars and teachers or consultants in that group, and they need to come up with the content. But you can't force this on the student. You can't say, I want you to be creative now. I want you to make content for me now. Because that way, I'm going to force a person to do something that they don't really want to do and that doesn't come from themselves. So you need to invite them, you need to ask them to participate first, then they start to collaborate, and eventually they start to create. And that's where you actually get the real transformation happening. So you can't force people to be part of it. You have to invite them. And then it becomes, the hierarchy of teaching becomes completely flat. It's not me telling you, I've got this red gown on and I'm going to tell you how it's done. It's us getting together and figuring out a way to teach your peer. And so this is how the chapters look like. There were quite a lot of these chapters. And the next one, Andrea Horn is doing the students platform, and she felt it's a bit boring to have this. And so she started to say, well, let's make posters from these chapters. So pretty much what happens now is, if you want to read a chapter, you can also have a look at the poster first and see if the chapter is really interesting to you or not. And you can refer back to the poster if you don't want to read through the entire chapter anymore. And that really makes it a lot more visual and engages the students that come after that written chapter to also think about the chapter themselves. And we had Jeannie McCall setting up a channel, a YouTube channel, where people could upload 4 to 7 minute YouTube videos that they produced themselves, and they used it to mainly augment or highlight certain learning points that they saw in their chapter that was important to them, and or something that they felt wasn't in the chapter that they wanted to include. And so that YouTube channel is really done quite well. It's got now 1.5 million views and good viewing times, and we've got 11,000 subscribers. So if you click on, that's pretty much how it looks like. You can click on the videos that you want to see, and if you click on them, it up pops an ad. That means we actually we could probably make money with this now. But I don't know how ethical that is. I've had problems with ethics this year, so I have to be careful. Can we go on? That was also published in the South African Medical Journal, so people can read up on it if they want to. Now, Vela and Pinda have now invited us to become their co-creators. So they came to our department and said, listen here, we want to create this platform, a learning platform called 4-Minute Medicine, and we want to include a chapter, we want to include videos, and we want to also include we want to ask the students to take some tests in that. And then they can figure out how good they are. So if you speak to Vela and Pinna, that's exactly how you feel. It's just like, and then afterwards you have to just pick up the bits and pieces and put them all together. But this is a platform that basically is now gotten traction, and angel investors have invested quite heavily into this platform. I'm very proud that they just came back from Barcelona. I think today they're speaking to Harvard, to the incubator, and I think it's really becoming very big. And it's fantastic to have the university here to tell them that as well, because it's obviously got orthopedics, but it's got all the other things as well that you need. Okay, and we can also in the background we can see how engaged these students are when they do their learning. So basically, in the students, what we've tried to do is bring them into our department. We try to be a little bit more. We try to flatten the hierarchy, and we try to create with them, and we hope that the effect of this is transformation. I want to talk to you about the registrars now, and they're getting tired in the back row there. I can see Brad is almost asleep. No, it's not Brad, it's Dane. Dane is writing. Dane is writing, that's an excuse. So in our teaching, we always think that we are the pinnacle. So in our registrar teaching, we think that we are here on the mountain, and we are the academic hospital, and we are the people teaching. But there's a disconnect, because we are teaching people that are supposed to treat South African patients in different hospitals, not just a teaching hospital, a big teaching hospital with all the resources, all the sisters that we have that support us, and the anesthetists that know what's going on, and ICU and everything. And so what we realized is that we needed to integrate the secondary level hospitals into our teaching platform. And that was mainly Steve and Rob that started to integrate that teaching platform and started to equip that teaching platform as well. So there's these 3 hospitals: Victoria Hospital, Mrs. Plain, and Somerset Hospital. And now we've got very good clinicians in these hospitals that teach our the people that become our registrars. So they actually start to recruit good people into our system, and then from those they teach them the basics. They teach them what to how to assess a patient, how to the first couple of procedures, and they also teach them the culture of our department. And so that's a very important step that oftentimes is not there. Oftentimes you just get a trainee into your department, and you need to make that trainee in 4 years, you need to make that trainee ready to operate. And this precursor of our training has really helped us to elevate our teaching. So I was 15 years ago, we didn't have this. And I was put by Prof Del Khan. There was no international registrars in the orthopedic department either. So they didn't know what to do with me. So they pushed me into Jooste Hospital. And I thought, you know, you have to drive to Mrs. Plain. I had this old car that always got stuck. And then I got these 2 Afrikaners there, Maritz Loubser and De Preenodier. Yeah. And the word rounds were like, you know, ons moet nou 'n kleintjie snytjie maak en dan 'n skroefietjie aansit. En jy's 'n pragtig geloop. I had my slap chips and stuff. But they also really took me under their wing, and they taught me a lot. And they really, they pretty much taught me everything that a consultant would teach now to our MOs in the periphery. And I was very lucky to have Maritz there. And he was then, he obviously got into the, you got into Tygerberg as well, and you passed it for like, you could have become a consultant a year earlier, and he decided to say no to Tygerberg Hospital. And he came here, and he was 3 months ahead of me always. So I'd always follow him through every rotation. And if you know Maritz, he's a very, I mean, Portia is smiling now. He's a very good clinician, and he's very good with people, and everybody loves him. And so if you trail Maritz in the rotation, it's not easy. And I had a bit of a chip on my shoulder going through the rotation, but I couldn't say anything because he was teaching me everything. And then 3 months behind me was Russell Govender and Kobus Mollmann, who were also fantastic. So everything I forgot, 3 months later, they would teach me again. So the problem is this, is at the moment we are producing these registrars, and this is Stefan Swanepoel, who's a very good pelvic surgeon, and he works with Thane Munting, who's sitting there in the back. Thane is actually teaching him, or has taught him quite a lot, but Thane never stops teaching. So he actually looked at our exam and he said, look here, there's these components in our exam. Which component is actually important for us? So he's probably one of the main reasons why we're doing MCQs now and not written exams anymore. But what he found out is that we're producing more and more registrars. And we're passing more and more registrars, and they're all pushed into the market. And the market for our registrars, for all of you up there in the last row, is going to be 9 to 1. That means 9 out of 10 out of you, 90% of you will end up in private practice. And only 1 out of 10 will end up in a government hospital. But we're teaching you in a government hospital for a practice in private. And so private practice is a red ocean. It's a shark tank, because there's people like Richard and Thane out there that've been, operating for 20, 30 years, 40 years, and looking young and younger as they operate. And you get in there and you have to compete with those guys. You know, you have to basically set up practice right next to Richard and Thane. And you're going to struggle. For a long time, you're going to struggle to actually even make even. And so we saw this in a study that Angela Dell did on South African orthopedic surgeons. And we saw that bad distribution of surgeons, all of them are crowded around the big cities, Cape Town, Durban, Joburg, and everywhere else is almost no one. So we're basically looking for 20% of people that are insured, and we're pushing 80% of our surgeons to those 20% of people that are insured. And the other 10% of surgeons are operating on the rest of the 80% of the people that aren't insured. So it's a big problem in our country. So now, Richard, he's right. It's really good to have a friend. It's something that I think a registrar needs when they start off. A fellowship means that you learn the skills and the knowledge a little bit better in that specific field. But a mentor is someone that brings you along and teaches you things that aren't in the books. And Richard's been that for me since I know him. Since Steve threw me out of the shoulder fellowship. I think it was that, Steve. I did one cuff repair and he says, no, Michael, sorry, you go down to the knee. No, actually, it wasn't like that. It was like that a little bit. Richard's all the best. That's his website. He's the best knee surgeon. ... So you can decide where. I think pretty much worldwide. Okay, go on. But what I like about Richard is he handed over the knee unit to me, and I'm sitting in his chair in private practice as well, only when I'm allowed to. And his whole family pictures are in the background, and people always ask me, "Ay, Jana, where's that young doctor?" I'm like, "I'm here." No, that young one. No, they mean Richard. Now go back to that. I want to just tell you, so I don't want to bore you with this, but these are all the publications that Richard and I have done together. It's mainly about complex knee problems. We both really enjoy it, but I think it's very boring to most of you. So I'm not going to bother you with this, but it's so nice for me to continue in a field that I enjoy with someone that's got the same passion as I do. Not just for my academic practice, but he's also a very passionate father. And we don't have that often. We don't have mentors that you can look up to in terms of their skills, but also in terms of their lifestyle and in terms of their values that they have. And Richard and Steve are both very much mentors in that. So these are my fellows now, and you can see the big eyes of Ashley Arakal. I said to him now, I have to go. And Ashley, it was Johann's first knee replacement. Is Johann here? There he is in the back row. It was his first knee replacement today. He was so chuffed. He was calm and confident, and he just, everything flew, you know, just. And I was sweating. I was sweating, and Arakal was these big eyes. But you know, that's what you need when you learn. You need to be a little bit uncomfortable, but you need to feel safe, and you need someone to really promote you and say, "Yeah, well done." And Richard did that to me, and I hope I can do the same with you guys now. And it's actually pretty much how Richard's teaching lives on, and it gets passed on. So do we prepare you guys well? We often talk about skills and knowledge, but I think our group is really special. It's very rare that you get, and I've been in different hospitals all over the, like Lydia said, I was that German student that traveled a lot and just hung out a little bit at the hospital and then skipped out to the beach. But I don't see this in other hospitals. I don't see this even in Orthopaedic. This is not very common, is that you have such a close community of registrars that really know each other well. And that breeds professionalism. When you see people doing clinical work well, you actually want to be part of that group. And if you see that they're enjoying themselves, it becomes a much more powerful way of learning than just doing it yourself. Now, the question is this: are we teaching you the right skills? And Cara Dunn was a 5th year student with, she's Rob Dunn's daughter, and she looked at how much you guys operate. And you can see half-half. Half is trauma, half is elective surgery. And within elective surgery, you're exposed to a lot of different subdisciplines. So you can see that that's the pie chart. And the columns will show you that you're operating most of the cases. All the gray and the red is operated by a registrar. And all the red and the blue, the consultant is available. So you see that you're operating almost 70% of the cases on the right-hand column. And in the elective arena, you're supervised in 60%. That's unheard of. There's no German, UK, American university hospital that has this. So our hospital is geared for training and for learning skills, surgical skills. And this is why I worked so hard to get in. You guys always work so hard to get out. It took me so long to get in. You need to appreciate this slide. We're obviously trying to improve the public exposure, and this was a little project we did where we took patients from Grooteskiel Hospital and we operated on them in a private hospital, and we were able to operate 30 cases there and save $1.5 million worth of money. Johan Leroux is sitting up there. He was my fellow. He's worked very hard on that list and also on the publication. And I don't know if Ramanar is here. I haven't seen him. He promised me to be here, but he set it up. And Wing was actually a registrar on that list. He was a patient on that list. We operated him on that list, but he was also a medical student. And then he published this article now with us in the SAOJ, in the South African Orthopaedic Journal. Okay, and then another good way to learn without operating on patients is to do simulation. And so we have these cadaver workshops where we teach, and we're very lucky because we get quite a lot of support to actually have these cadaver workshops for every 6 weeks. A cadaver is a dead person, and then you basically, they give you approval that you can use them for training purposes. And you can see there's Kirsty Berry. Kirsty not here, hey? She is here, Kirsty. Kirsty just was in a fellowship in London. She did a double fellowship. She's an arthroplasty trained trauma surgeon, pelvic surgeon, now finally back to us. So she made it back, which is really, really special. And this is Kirsty here with the little blackboard. So she was always very interested and was always very diligent. And she thought, oh, I want to understand how well my colleagues can do arthroscopy, so keyhole surgery. And she did this. We did this project together, and she saw that these bar charts show you that they're actually good, but they're very varied. There's a lot of variance, and it's not the more advanced registrars that do better. The registrars come into our program, and whatever they learn, that's how they are. So we didn't really advance our registrars in keyhole surgery during our registrar program. That's not good. And we realized that the exposure and the experience are not the same. So we can expose you to these techniques, and someone that's standing in the back row might not have the same experience with it. And we have to almost standardize training. Skills training needs to be standardized. It's difficult to give you the same exposure if 5 people are standing around a cadaver and 1 is operating. Kirsty now went to London and she presented to the British Knee Society meeting there, and she also published this in the JBJS. So it's a massive achievement for her. She got a cum laude for this. This is a very important paper that really shows us how we need to change our skills training. And so we are looking into that, and we are now looking into virtual simulation where we can actually standardize the procedures. And also you can see down here, there's safety scores, scratch scores, movement scores, time scores, and they all get added up. And then we can have a registrar, which is one of these blocks here. We can see the trainee 1 did well, and then he dropped, his learning curve dropped. Maybe he got tired. Whereas trainee 4, actually his learning curve is rising. So we should give him more time. And there's other trainees that just tried once, maybe either because they're very good or very bad, or maybe they're just not interested in knee arthroscopy. And Johan, I've got your score of this as well. Johan wants to do the knee fellowship next year, and I'm going to just have to look and see how many times you try. No, I did already. It looks good, Johan. Don't worry. So the last thing that I want to chat to you about is it really important to do research? Yeah. And when you look at orthopedic registrars, they're strong people, and I'm sorry it's not working, but in the end, we're not becoming orthopedic surgeons to do research. We're not like the biology guys or the biomaterials people that love to do clinical work, but mainly for research. We just want to operate. And so we often wonder, is it really important to do, is it really important? Sorry, that video scared people. I'm going to keep using Richard, that was us a couple of weeks ago. I was holding on to leg. It was actually Richard doing all the hard work here. No. Do we need research? I can't answer this question right now, but I think we need to understand data. So we need, as a registrar, orthopedic registrar, you need to understand data. Data that you read, that you want to implement in your practice, but also data that you produce in your practice. Whether you're in private practice or in state practice, doesn't matter. In private practice, it's important to know how well your patients do, the same way as in state. But it's important to support the registrars. And oftentimes, if you just push a person into a research project and you don't support them, then it becomes frustrating and sometimes daunting, and it becomes a mission for everybody. And some of us have been there as registrars, and others also as supervisors. So what we started to do a focus on support for the relevance and the relevance in what we do, and also kind of an umbrella basically for research for orthopedic registrars. We wanted to invite collaborators into our unit. So that's why I see Yaku here. I see Malcolm Collins here. Is it Alison, is she here? There she is. They're all bright minds. when they give a talk to us, it completely flies overhead. But they want to understand our questions, our challenges, so that they can plug their research in. And that's basically the research unit is a platform to do that. And we wanted to make sure that we get our own agenda. So we wanted to do research on things that we think are important. We wanted to house our data in a way that's safe for us. And we wanted to collect tissue. Tissue for a surgeon is so easy to get, but for scientists, very difficult. And so that's our bargaining power. That's how we get them in. And so it's a quid pro quo. Now, I want to introduce you to Simon. He's a UK-based surgeon, but he came to us for a year or two for his PhD. And he literally turned our unit around by showing us how to do proper research. He's a Wellcome Trust Fellow. That means he's got lots of money behind him, grant money, but he's also very clever. And Sitombo was a PI of the study and put a lot of work together with Maritz, put a lot of work into it. And so they looked at HIV and how HIV affects bone healing. And you can go on to the next one and click, 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 click. These are all the publications they've published in the last 2 years. Click, 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 click. So you can see how productive this collaboration was. And it's basically just bringing one person into our unit. And he recruited other people. He recruited a research team with nurses, research nurses that are very important for us. And they've just recently even got a huge grant, over 20 million rand grant, that's going to also be managed by Sitombo and him to come to our unit. That's massive. That's beyond what we thought it would be. So go on. We spoke very little about a little bit about the global surgery unit. What we want to do with that is improve systems around us, so not just get our registrars more trained better for a certain system, but also improve that specific system. That's also grown beyond us, and I'm glad that Graham Fegan has taken it and made it into a whole unit. So there's a person that now heads that, and we've got also Sitombo and Kutsai Chironga, who are basically our orthopedic representatives in that group, make sure that they also include lots of orthopedic projects in that group. But that's pretty much something that slowly started also within the orthopedic research unit as an MSc in global surgery. Now, Robin Waters is here. She's sitting in the back with her father, and Simon introduced her to us. And she was very keen to understand how to test tuberculosis in the body, and especially in the spine. So the spine is very delicate to take tissue from. You need a spine surgeon for it in most cases, and it's anatomically it's very difficult to get the tissue out. So what she wanted to do is actually see if we can diagnose it in blood, which is not really done yet. So she's done her PhD on it, and she's passed her thesis now. So she's our first PhD that we produced in the orthopedic department, which is a real big achievement for her and for us, Robin. Yeah, you can give her a hand of applause. Sure. And then I can see Julian Scherer up there. Julian is also a PhD student, and he's taken it a little bit further. He wants to understand how TB gets into the bone. So TB is a lung disease, but how does it get into the bone? So he's basically showing, he's using PET CT scans to figure out where the patient's infections are. If the patient has a spine infection, he wants to understand where the infection, if there is an infection in the lung. You could see he also found true love in South Africa. That's his new puppy. Okay. So Robin is now taking on the role of understanding research a little bit more in our department and supervising both the students, but also helping the supervisors themselves with it, and basically organizes our data and tissue bank. Now, Steve, you can see he's swamped with hard clinical cases. These are all gunshot injuries of the humerus. He's an upper limb surgeon, and he needs to sort this out. So he thought, let me just collect them all, look at them all, and then figure out where they break. And then you go on. and go on. And then he basically has a biomechanics lab now that works with him, that maps those fractures, a heat map. And then based on that heat map of the fracture, he can design a specific plate that works for specific fractures. And that's just how it basically started. They're now designing implants as well. In the sports injury clinic, you can click twice, is a combo of a project that is inviting good players that need help in terms of surgery into our hospital, but it also combines all these great physiotherapists, sports physiotherapists that come to us and help them. So two of them are sitting here, Leandri and Helen, and they basically come every week without pay to help and rehab those patients that we operate. And they're often high-level athletes. They're Springbok players, Western Province players, world champions, but they just don't have the money or the support for medical aid. And Steve basically does the shoulder, Graham does the ankles, and I do the knees. And so, yeah, the research unit has grown. You can see the publication count has grown, but what is more important is that we have focused. I think we've shifted this. Initially, I was very much chasing the registrars for the MMeds and chasing our publications, sitting down and counting. And I realized, actually, if we invite people into the unit and they enjoy working with us, then the publications and the productive stuff comes on its own. So I think that's a huge learning that I've gone through. And because I always thought it's the goal that makes the difference, but it's actually the way to get there. And I think that's something that we have in the unit, in the research unit, but it's more so in our clinical unit, is that we enjoy keep on learning. It's that we listen, and hopefully we listen to registrars and students to figure out how they want to train and to grow a team culture and make sure that you guys can get out into the world. And so last slide, guys. This is my daughter, Olivia, who's now either passed out or she's outside. And she showed me her Barbie broke her leg. And she says now she wants to come to work and fix it. And I said to her, well, that's nice. And, you know, there you see, I actually want to tell her, yes, you must go and come into the orthopedic department and study here and train here and work here. And this is basically what we want to work on, is that we can invite our kids in the future into a department that can elevate them, but doesn't break them during that time. And that's pretty much, I think we are on the right way. And I hope we'll get there. Thanks very much, guys. Short. Thank you very much. Thank you. The mic or the water? Both.
Okay, great. Well, thank you so much, Michael. That was absolutely fascinating, illuminating, heartwarming. Well done. It gives me pleasure now to invite Professor Maritz Loubser to deliver a vote of thanks.
Thank you very much. I have to confess that I recently missed Lydia's inauguration because I was stuck in theatre, so I missed the opportunity to get, a brief of what a vote of thanks should be. But just on a personal note, I thought I have a few things to just set straight in the history, because I know Michael would leave a few things out, and then from the department, Michael is a very humble person, and also we knew he would leave some of his achievements out. So just very briefly want to focus on a few things. So I had to dig really deep to get a picture of Michael from our early sort of years together. He's a very private person. I decided I'm not going to take a picture of the internet because we've had enough of those in the past. This is a picture of the early MO days. And we started at UCT, like Michael said, together in 2008 as orthopedic MOs. Like I was saying, we were learning surgery, so we were all super excited about all the complex cases that we were going to operate on. And but Michael's slightly different. You know, he came with a European background, and not only did he recognize the interesting cases that we need to learn, or operations we need to learn, he also asked, you know, we should write this up or we should see what the outcomes were. And those were certain very foreign concepts for us at the time. So we later became registrars together, and we had a very fruitful research collaboration together that's still ongoing. So our first publication was in 2011. I'll show something about that now, and we later both became consultants here. So our first publication was so long ago that neither Steve or Rob had any grey hair, as you can see in the picture there. And you can see all of sort of this first publication together was all on spine topics, shoulder topics, even hands topics. And I think that just really reflected our bosses or our mentors at the time. We still have a very successful research collaboration. We have moved on to more interesting topics. Sorry, Steve and Rob. And yeah, looking forward to that continuing. So from a department point of view, I think, you know, we sort of focus on Michael's input in the sort of three aspects of surgery, research, and then training. So firstly, just looking at surgery, I think a lot of Michael does is, you know, is innovative, and not only innovative in treating difficult conditions, but also a cost-effective solution for our local context, where often the prescribed methods are either too expensive or not available, you know, in our setting. He also put a lot of work to improve access for patients, specifically neglected conditions like sports injuries. You know, in a research-constrained environment, we so focus on the urgent conditions, you know, like cancer, trauma, whatever comes to the door, that often a big population of patients are neglected, specifically sports injuries. So setting up a sports injury clinic and getting rapid access to these deserved patients, you know, played a big role. Also increasing our footprint of access for patients to do non-urgent operations, because we can seldom compete, you know, here where there's more urgent operations that need to be done, by improving our increasing our footprint and able to do some public cases in private. From a research point of view, well, first thing I have to say that, you know, getting orthopedic surgeons enthusiastic about research is very difficult. You know, most orthopedic surgeons like to operate. Even clinical duties like ward rounds and clinics is not really their thing. They just want to operate and get home to practice their hobbies, which can be anything from adventure sports or you know, whatever. So Michael was the first orthopedic surgeon in our department to get a PhD while I was still a registrar, which is a massive achievement. I remember when we were Regis and we were starting this big TB spine project, when he asked me, he really thinks this project could be a PhD. What do I think? And just I was like, that never crossed my mind before, but I said, I'm sure it could be, and it's fantastic, and I was glad to be part of it, and that was a massive achievement, being the first PhD in our department, and while he was still a registrar. He set up the orthopedic research unit, and unlike what he said, it was all him, and he also focused all our research into you know, sort of research streams to make us more effective, and gave it good names, as you could see here. You know, orthoballistics sounds much, you know, more likable than, you know, gunshot fractures. Muti for TB spine, and Gogol for our fragility fractures. He started the ORU, as I said, and also our research symposium, and these all became, you know, much more organized than they used to be in the past. Also, what I didn't mention is set up and successfully supervised the first MSc in orthopedic surgery and global surgery, and PhD in our department. Robin, first successful one, and current 4 ongoing ones at various stages of completion. And then lastly, just about training. Again, you know, I'm not going to repeat everything that Michael said, but mostly all of the innovations in our department in training is in some way either started or pushed along by Michael. Undergraduate, the textbook, the new curriculum. For the postgraduates, the cadaver workshop, improving training and arthroscopy, and again other aspects of orthopedic surgical training where we don't get such big exposure here, compared to trauma. Our UCT YouTube channel, as Michael said, we've got 1.5 million views, almost 12,000 subscribers, and where we just literally publish free contents and all our lectures, which the main thing is give other places, other parts of the country where people work but they don't have access to training, and the rest of Africa access to our teaching content that we give to our registrars. Also set up an outreach and also a successful fellowship program training other knee surgeons in South Africa. So Michael's all about lifestyle, and he always talk about finding this sweet spot. So so from the department side, thanks, Michael. And so we still hang out, but it's a little bit different now. No more wild parties. And yeah, thanks, Michael, for helping us find that sweet spot in the department.
Kaisekai Gangans is the way in which the original people in this area would have said thank you. And Michael, it's a really deep sense of gratitude having heard that discourse of yours this evening. I'm not sure if you recall, Michael, that the first time you met me was at a 7 o'clock meeting when I called the consultants of orthopedics to come to my office in 2020. Well, that wasn't the sensitive moment, I should just point out, because one of Michael's questions at the end of the conversation was, what do you want from us? We're excellent. And my response to him was that excellence is multidimensional. And I want to say Kaisekai Gangans this evening for that demonstration of excellence, because in fact, in your discourse this evening, you've given us a sense of that excellence across a range of areas. But perhaps for me, the most important reflection of excellence is that in an academic inaugural lecture, you showed 6 slides of your family. That for me is the excellence that we seek, and that is the excellence we don't always get right. But I really want to thank you for that, because the other story that started outside was that one of Michael's daughters asked, why are you dressed like that? Or why do you have that on? And Joanne, I think, was trying to be proper to say that that's what professors wear. But Michael's response was, in fact, we're just dressed like Harry Potter. And for me, I want to say thank you to Joanne, because I think that we have very few occasions where family come into the scholarly or clinical environment in which we just say thank you. And I want to say to you, I mean, as a partner to a person who's clearly doing a lot of stuff, so you're clearly even taking photographs of Joanne doing all the other stuff that perhaps you may want to contribute to. But to the children, Hannah, Noah, Maya, and Olivia, thank you for being a part of, for seeing what your dad does on the other times when he's not at home. But I really want to thank you for foregrounding family in a way this evening that I think is a really important symbol of our scholarship and the scholarship we aim for as a university. To Johan is Jan's dad, and then Thomas and Annie were here from Germany visiting us for this lecture. It really locates this idea that we see a little bit, even for a little while, where people who become scholars have come from, and recognize the contribution that they're making. I want to just reflect on some of the things you said today, Michael, because I think essentially what I had a sense as I listened today was this idea of being schooled in education. You know, I've been promoting these inaugural lectures as an integral part of what a faculty does. And And so there are a couple of things that have happened at surgical lectures that have been quite innovative as we've come through. So the first one was, I think, Stephen's lecture where somebody from the private sector did the vote of thanks. I'm not sure that that had been tradition before. And then at Lydia's, we had a community member speak. And I mean, there are other innovations that have happened. But I have to say, it's the first time that the wine has been brought into the inaugural lecture. And I suspect it might well happen at an orthopedic event. But I want to just lift some of those things because, Michael, what you taught us this evening is that integral nature of a teacher. You stepped away from the podium in many ways, risking what happens when you do that. And it's an important thing for us to step out of our comfort zones into the risky areas. But you also talked about a thing that I don't think we always give our students the capacity to do, to actually show us where to go. That concept of when you show those pictures of sometimes you don't have to talk when you're teaching. I think it's a really important thing, especially coming from a discipline where the doing is so key to all that you do, all that you are, I think, as orthopedic surgeons. So thanks very, very much for that. And I think that as I reflected, this idea of the round of applause that you gave for leaders at the beginning, and recognizing the struggle that it is being a clinical leader in this environment where the austerity will come to affect us in ways that we still don't understand. So thank you very much for that, because again, the comment by Rob Dunn that you're restless in innovation, thank God you choose this place for that restlessness. We're deeply grateful that it's in this space that you choose to have that restlessly innovative spirit. And then that last comment, and perhaps before I do, the other thing I often say at these occasions is really to reflect a little bit on the fact that we're a place with a long history. And just next week, we will be taking the remains of the Sutherland 9 back to Sutherland, where they were taken illegally from, and then housed in the anatomy lecture in the anatomy laboratories for the last 100 years or so. And part of that story of our vulnerabilities from times past to our successes in this era, as that teaching paradigm shifts, my takeaway from today is this idea of elevate without breaking. Because that's the integral part. I've just been at a meeting where we were talking about the fact that our programs, our registrar programs, our undergraduate programs in the health sciences are really, really hard. They don't have to be unkind. And so as I leave today, I'm really taking this idea that you have learned from your colleagues and you yourself demonstrate this idea with your own teachers and co-researchers that we can elevate without breaking. Thank you very, very much for this evening. And so, colleagues, it remains for me to invite you to refreshments outside, just to enjoy this communal event, because this is who we are. This is what we are trying to be as a faculty, a community in which our scholarship, our clinical service, and the intersection of communities becomes real in what we do as professors and those who work together. So thank you very much. Please join us outside. I'm going to ask you to stand as the procession leaves.